weakness, ankle swelling, and fatigue that may be accompanied by physical signs, elevated jugular venous pressure, pulmonary crackles, and peripheral edema caused by structural or functional cardiac abnormality, which resulting in reduced cardiac output or elevated intracardiac pressure at rest or during stress. So to have compliance of breathness of dyspnea, it's not enough to put the diagnosis heart failure, because you must confirm the structural changes in the heart, which can lead to that compliance, because somebody, young man, can tell you that have dyspnea as running as elevated seventh floors, but it's normal to have some compliance. This dyspnea may be due to pulmonary disease, may be due to tachyarrhythmia, which may be functional changes. So it's very important to have not only compliance, but and the structural changes of the heart. The old definition is on inability of the heart to pump water at sufficient rate to meet the metabolic demands of the body, oxygen and cell nutrition at rest and during effort, or to do so only if cardiac filling pressure are abnormally high. But the most important, that is due to structural or functional cardiac disorder that impair the ability of the ventricle to fill or to eject the blood. The significance of that disease is very big, because the frequency increased with the age of the population, because it's meeting more often in older people. And if the symptomatic heart failure until 65 years is only 0.5% to 2%, as you see in people over 65 years, increase to 6 to 8 to 10%. That's why that is the disease in the elderly. And if they have not treated their heart condition, this heart failure progress with more often hospitalization, rehospitalization, and also have more comorbidity, which also increase the fatal risk or the resistance of the heart failure. So the prevalence is rising, and the bad prognosis in one heart failure, third or fourth functional class, as you see, is more than 50% survival, under 50% survival rate. And a lot of improving of the treatment of the heart failure, as with drugs, as with interventional treatment, but yet still symptomatic heart failure carry a poor prognosis, and most of patients with the diagnosis will die to 5 years, which may be due to sudden cardiac death or worsening of heart failure. And functional status is important predictor of patient outcomes, as you see, as increase the functional class to 3 to 4, increase and the mortality rate. So the main reason for the heart failure, first of all, as you see, is ischemic heart disease, cardiomyopathy, especially dilative cardiomyopathy, which secondary forms ischemic cardiomyopathy, hypertension. Other causes are valvular heart disease, talk about degenerative aortic stenosis, some congenital heart disease, not operated, or some forms of cardiomyopathy. The etiology of the heart failure is very, very different, and our task is to put the diagnosis on time to stop the progress with treatment, or if the patient can be operated, to think in this direction. And as you see, maybe coronary artery disease with myocardial infarction, with myocardial ischemia, indifferent hypertension with diastolic heart failure, chronic volume overwork, maybe give valvular disease with regurgitation, and the heart failure is divided in two big forms, systolic and diastolic. And in diastolic heart failure, the ejection fraction is normal or nearly normal, but have hypertrophy. And this hypertrophy is in connection with diastolic heart failure. Pulmonary heart disease may be giving right heart failure, or pulmonale or pulmonary vascular disorder. Some high output status as metabolic disorders, stereotoxicosis, nutritious disease. Restrictive cardiomyopathy may be giving also diastolic heart failure, elevated filling pressure, and all other forms secondary of the hypertrophic cardiomyopathy or restrictive cardiomyopathy. So to maintain normal cardiac output, several compensatory mechanisms play a role and these compensatory mechanisms from one side are compensatory enlargement in the form of cardiac hypertrophy, cardiac dilatation, or both, activation or hyperactivation of sympathetic nervous system and neurohormonal system, especially renin angiotensin system, with release of noradrenaline or natriuretic peptide, also activation of aldosterone mechanism. And as understand the compensatory mechanism, you will understand the main action why AC inhibitors nowadays improve the prognosis of the patients with heart failure because they are counteracting of the activation of the renin angiotensin system. Why the beta blockers also improve prognosis, because they are counteracting to hyperactivation of the sympathetic nervous system. Reduced contractility due to overloading of the ventricle, reduced stroke volume, also activated other system, sympathectomy, increased heart rate, also worsening ischemia, increased decreased the filling of the ventricle, because the filling of the heart is in diastole, and every tachycardia reduce reduce the feeling and the cardiac output. Food from other side, compensatory hypertrophy, reduced cardiac reserve, and increased stiffness and impaired diastolic relaxation. The consequences of all these mechanism as activated blood pressure falls and stimulated activated sympathetic activity that increased heart rate and increased peripheral vascular resistance, activated adrenaline angiotensin system with vasopressin release that promote fluid retention by kidney to raise blood volume. The angiotensin renin system is not only in the in the tissue of the lens, it is in the vessels, and that's why all AC inhibitors have also and pleiotropic actions and reduce kidney perfusion. From one side, activated renin angiotensin system, which causes vasoconstriction of the afferent arterioles and that lead to salt and to fluid retentions. So from other side, endocrine hormones can cause structural remodeling heart. You must be remember that eplerenone, that spironolactone acting and improved remodeling of the left ventricle in the patients with soon myocardial infarction. Also, vasoconstriction increased blood volume and that increase capillary hydrostatic pressure that leading to edema, which may be pulmonary or peripheral, and from other side, reduce pulmonary blood flow or edema cause hypoxia, promote pulmonary vasoconstriction that lead to pulmonary hypertension. And what are the compensatory mechanisms? From one side, ventricular dilatation with increased natriuretic peptide secretion. In nowadays, as maybe here, the drug rescue, which is neprilysin inhibitor, but natriuretic peptides, which have not been only marker for heart failure, but also have an physiologic action. And all mechanisms are in connection with salt and water retention, with sympathetic stimulation, peripheral vasoconstriction, with compensatory idiot to maintain adequate cardiac output and peripheral perfusion. From the changes which are happening in the heart is ventricular dilatation, myocyte hypertrophy, increased collagen synthesis, and also decreased metabolic needs, which also have changes or with apoptosis, with other changes in the myocardial, and from the hemodynamic and physiology with sympathetic nervous system and peripheral vasoconstriction. From one side, cardiac output is affected from heart rate, stroke volume, from afterload and contractility, and also preload. Do you remember about what is the preload? That is the length of the cardiac muscle fiber prior to the onset of the contraction. If you remember, the Frank-Starling mechanism, which were in physiology more potent contraction and dilatation and that compensatory mechanism are to that to one moment. If exceeded that dilatation, the ejection fraction, the contractile function of the left ventricle fall. Afterward is muscle against which a cardiac muscle fiber must shorten. That is the isotonic contraction. Of course, it will be for as the have dilatation, and the force of the contractility is independent of the pre-wall and afterward, and in different mechanisms of heart failure is happening different changes. So the pre-wall is the volume of blood or amount of the fiber stage in the ventricle as the end of the diastole before the next contraction, and it increases with volume increases and vasoconstriction, and decreases with fluid volume losses as diuretic treatment and vasodilatation. In the pre-wall, afterward, that is the resistance against which the ventricle must pump, and excessive afterward is difficult to pump forward, which lead to reduced cardiac output and afterward increase in hypertension, in vasoconstriction, and decrease with vasodilatation. So with ACE inhibitors, with vasodilators, may improve this pathophysiology mechanism. In the normal state, as you see here, the mechanism of Frank-Starling with dilatation, and in the heart failure decrease the pump function with more potent contraction of, but as the talk, that is the one moment. Renin-angiotensin system is other system which is taking part in the pathophysiology of the heart failure. First of all, angiotensin again is converting in angiotensin 1 every sympathetic activity from one side, from other side, and other previous mechanism of the heart failure is taking part of activating of that system. And as you see, the angiotensin converting enzyme acting in conversion to angiotensin 1 to angiotensin 2, and angiotensin 1 is the more potent vasoconstrictor, which of course increase and vasoconstriction as talk on and the level of the vessels and on the level of the tissue, and taking part in the vascular remodeling and left ventricle remodeling with cell growth, and so of the changes on the myocyte level. Activation of the hypersympathetic activity system from one side, the sympathetic nervous system activated renin-angiotensin system, and all this hyperactivation lead to fibrosis, apoptosis, and hypertrophy with cellular alteration and myotoxicity, and to remodeling and progressive worsening of left ventricle function, which increase the risk of sudden death of heart failure with systolic dysfunction and appearance of the symptoms of the heart failure as fatigue, decreased functional class, and peripheral edema and pulmonary congestion. So the adrenergic pathway in heart failure is in connection with failure progression with compensatory acting. That's why the beta blockers are improve the prognosis of the patient of the heart failure as decrease the heart rate, as decrease the sympathetic nervous activity systems, and as giving ACE inhibitors can improve and that hyperactivation of the renin-angiotensin system at the contracting to the peripheral vasoconstriction and myocardial toxicity and improve the prognosis of the patient because the progress of the heart failure is in connection with the myocardial remodeling with transition from compensatory hypertrophy to heart failure because in the heart failure there is activation of different prostaglandins, different cytokines, which also on the level of the myocyte acting to their apoptosis, to the myocardial remodeling, and that lead to decreased oxidative stress and also remodeling and ventricular enlargement of the heart. So all hemodynamic basis for the heart failure symptoms from one side are in connection with elevated filling pressure, left ventricular and diastolic pressure, normal to 12, and also left atrial pressure compensatory, which is giving pulmonary congestion, pulmonary capillary pressure increased, which lead to one pulmonary hypertension. What is the classification of the heart failure? It may be left sided and right-sided or total, may be compensated and decompensated, and acute versus chronic, high versus low output congestion or hypodiabetic. In the systolic heart failure, the ejection fraction is reduced, have big sizes of the ventricle, and clinically present with the left ventricle failure and marked cardiomegaly. In diastolic heart failure, the filling pressure increased, the ejection fraction is normal, and here also present with pulmonary congestion. That's why the echocardiography is very important of the diagnosis of the heart failure because can give you ejection fraction, can give you hypertrophy, and to decide it with what to treat patient because if one diastolic heart failure, as you see, the compounds may be again the same dyspnea, but they have improved in diastolic heart failure with vasodilator, with also beta blockers control of risk factors, because diastolic heart failure is more often in patients with comorbidity, with atrial fibrillation, with diabetes mellitus, with renal failure, and in these patients is not the therapy yet which improve their prognosis. In the systolic heart failure, the therapy with ACE inhibitors, with beta blockers, with all improving devices as resynchronization therapy can improve the prognosis. Not is the same in diastolic heart failure. What are the big reasons for the systolic dysfunction? As you see, coronary artery disease in first place. That's why it's very important these patients to if receive myocardial infarction to be on time performing recanalization of the myocardial vessels with percutaneous interventions if patients have angina and have data from the coronarography for 3 vessel disease with significant even 1 vessel disease to be revascularized and that will improve prognosis. First of all, hypertension, if not treated on the time, as you see, these changes progress to systolic dysfunction, valvular heart disease also. For the diastolic dysfunction, first on time, of course, hypertension, of course, coronary artery disease, which every ischemia giving diastolic dysfunction, hypertrophic obstructive cardiomyopathy, and restrictive cardiomyopathy, for instance. Other types as talk could be left-sided heart failure, right-sided heart failure, or total heart failure. In the left-sided heart failure, the reduction of left ventricle output, increase in left atrial pressure, pulmonary venous pressure, the picture of pulmonary hypertension with clinical appearance of pulmonary congestion to maybe edema, and presents with dyspnea. In right heart failure, if occurs in chronic lung disease as core pulmonary valve disease, stenosis maybe, is reduction of the right ventricle output and back pressure on right atrium, and that's why the clinical picture here is with increased jugular venous pressure, liver enlargement, peripheral edema. In the total or biventricle failure, have the combination of all these signs, and both ventricles are affected, dilative with cardiomyopathy, ischemic heart disease with also pulmonary hypertension, signs of right ventricle failure. The heart failure may be chronic most often, but every chronic heart failure maybe have episode of decompensation for with different aggravating precipitating factors for decompensation to be acute form of heart failure. That's why it's very important to know that reason and to quickly influence them with the treatment. From other side, chronic heart failure maybe have subclinical systolic dysfunction. The patient have parameters as in one myocarditis as is one diotative cardiomyopathy, and he has no complaints, have only structural disease. And in this patient, as stop the toxin action as in one alcoholic cardiomyopathy, as begin early therapy or with AC inhibitors with beta blocker can decrease the progression of the heart failure. And right ventricle systolic dysfunction may be also due to a right ventricle infarction. It's very often in combination with inferior myocardial infarction, and the clinical picture is different. The patient is with hypotony, with distanced neck veins, and must treat it with infusion with sympathetic mimetics, because the the ejection fraction of the right ventricle will be decreased, and chronic heart failure due to diastolic heart failure have other mechanism with impaired left ventricle relaxation is abnormal. It is only the early changes and all hypertrophy. It have increased stiffness, more patent contraction, more stress to eject the blood, and that's why can decrease the left ventricle compliance that lead to decreased diastolic ventricular filling with reduced cardiac output with compensatory increased filling pressure, but the ejection fraction is normal or nearly normal, and the reason for the diastolic heart failure is hypertension, hypertrophic cardiomyopathy, or restrictive cardiomyopathy. So the clinical syndrome of the heart failure, as talk, may be acute form and chronic heart failure. The definition, as you see, according to the ejection fraction is with low ejection fraction. As you see, must have several criteria, symptoms and signs of the heart failure. If the ejection fraction is under 40, between 40 and 50 is mid-range ejection fraction and heart failure, because it's not the same clinical picture, it's not the same prognosis if the patient have ejection fraction 20 and the patient have ejection fraction 40, 45, and also must to put the diagnosis of the heart failure to have elevated levels of the natriuretic peptides, and we'll see the values according them have a reason for heart failure, or if the natriuretic peptides are normal, the dyspnea is not due to heart failure. Must have relevant structural heart disease and diastolic dysfunction. In the heart failure with preserved ejection fraction, the ejection fraction is more than 50. Again, have signs, elevated levels of natriuretic peptides, and also have left ventricle septum hypertrophy or restrictive type model of dysfunction. What are the symptoms in the left-sided and chronic heart failure? Exertional dyspnea during physical activity and orthopnea. Maybe you remember the different degree of dyspnea at rest, exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Other symptom is fatigue, and these symptoms are combined with the signs of the chronic heart failure. In the left side, it maybe have pulmonary areas of congestion, mitral regurgitation relative or functional displaced apex from the cardiomegaly, sound 3 go up, rhythm accentuated pulmonary component, component in pulmonary hypertension. In the right-sided heart failure, peripheral edema, hepatomegaly can have ascites, abdominal bloating, nausea, anorexia of the hyperperfusion of the gastrointestinal tract. So from the physical examination, maybe see a displaced apical impulse inferiorly or laterally, maybe palpated in severe left ventricle hypertrophy. Signs of sound 3 go up, which is in systolic heart failure, and also maybe have relative mitral or tricuspidal regurgitation and systolic murmurs. Sound 4 go up is usually present in diastolic dysfunction persystolic. Per abdomen, maybe have hepatomegaly. Patients maybe have ascites, jaundice, even elevated transaminases, and with improving the congestion, the transaminases decreases and improve and the size of ascites also, and the peripheral edema may be at sacrum, pretibial, and with the picture of anasarca with pleural effusion, with even pericardial effusion due to congestion. Cardiac cachexia is due to hypoperfusion of the all organs. That's why this patient in systolic heart failure have not to react to diuretic therapy and must improve. In hypodiabetic heart failure, with the low ejection fraction, improve the blood pressure, not to be with low blood pressure, and even in these patients with heavy dilative cardiomyopathy, making infusion with small doses ateronol and dopamine and dobutamine to improve the contractile function, to improve the perfusion, and also continuous infusion with diuretic to improve the diuresis and to improve the edema signs of the legs and dyspnea. Other important comorbidities as talk, especially in heart failure, are atrial fibrillation, more often in hypertension in patients with with systolic dysfunction, anemia, as you know, also even in patients not so high degree, and in nowadays you can hear maybe that this anemia is improved with treating of ferro preparations because improve and functional class of the patient, and that's why must think to treat all comorbidities of the patient. Diabetes is especially very important comorbidity. From one side, the diabetes may be a reason for diabetic cardiomyopathy. The patients with diabetic are more often with hypertension, with early accelerated coronary artery disease, and from other side, they maybe have no typical chest pain. They maybe have an peripheral artery disease, and these patients maybe have most often dyspnea, which may be equivalent to angina, and must think and looking in them for heart failure and ejection, and they have a very good effect from the treatment with AC inhibitors, with beta blockers. From other side, some drugs have protective who are used for the treatment of diabetes have nowadays protective effect, improve and progression of heart failure, and that's drugs are diffusing and not only the diabetes but also and obesity and metabolic syndrome are also in very nearly relation with diastolic heart failure, and all treatment of this comorbidity is very important to decrease the progression of heart failure, especially in patients with chronic kidney disease and chronic pulmonary disease, and they have the patients with chronic kidney disease are the patients with high cardiovascular risk, and they must be treated from one side in the same manner, but according their renal function as the other patients in heart failure. So some of the symptoms and the signs are typical for the chronic heart failure, but the other side must make differential diagnosis of the all components and signs, as the breathlessness may be due to pulmonary disease, may be due to some thyrotoxicosis, orthopnea, paroxysmal nocturnal dyspnea is not only in left-sided heart failure. Reduced exercise tolerance may be have due to other reason, fatigue and tiredness also must looking for structural changes. Less typical, as you see, are nocturnal cough, loss of appetite, which may be in the late stages or if the patient take a lot of drugs for his heart failure. Confusion, especially in the elderly, may be due if the patient come with cardiogenic shock and brain hyperperfusion, can think that have myocardial infarction, and syncope also may be due to hypotonia, may be due to rhythm disturbances, SAV block, bradycardia, and also must think from one side of the side effects of the drug, from other side for the all comorbidities and other risk factors in the patients with heart failure. More specific signs are elevated jugular venous pressure with hepatojugular reflux, third heart sound, but less specific, is weight gain more than 2 kilograms of weight. That is more important and easy parameter to control is the patient control his weight. His therapy is adequate and he can give a good diuresis, because if he have take his diuretic and have dyspnea and have weight gain more than 2 kilograms of weight, he must discuss with his doctor to increase his diuretic or maybe something change. Also, weight loss in advanced heart failure, new onset cardiac murmur or worsening of the murmur in the patient who previously know his auscultation may be due to progress of his aortic stenosis or mitral regurgitation, and to think about hemodynamic appreciation and again echocardiography, also tachycardia, irregular pulse, new onset atrial fibrillation can worse heart failure, can be a risk for embolic incidents, and this patient is indicated for anticoagulation. Chain stocks respiration is maybe due and to other reason that then heart failure status also to different liver diseases, and edema may be due to renal disease, this renal insufficiency. So must make differential diagnosis, make non-invasive investigations, laboratory test or imaging to diagnose the reason for that signs and compliance. The severity of the heart failure in nowadays is appreciated according to New York functional classification. In class 1, no symptoms, with ordinary activity even more bigger than ordinary activity. The patient maybe have structural disease, maybe have risk factor, hypertension, diabetes, but they have no symptoms and signs of heart failure. And in this class, they do not need to from diuretic, but they may have treated with ACE inhibitors, with beta blocker to decrease with drugs which improve the prognosis of the patients with heart failure. In second class, have slight limitation of physical activity. The patients are comfortable at rest, but ordinary physical activity can result in fatigue, palpitation, dyspnea, or angina. In third functional cause, marked limitation of physical activity, comfortable at rest, but the physical activity less than ordinary physical activity result in fatigue, palpitation, dyspnea. And class 4 functional is unable to carry out any physical activity without discomfort. Symptoms of cardiac insufficiency may be present even at rest. So, as you see, these values class functional 3 or 4, you can imagine that this patient is decompensated, that he have need from a hospital treatment to improve his to improve his compliance with increased diuretic therapy, or to see what precipitated his heart failure, and to help him. So other American classification is other 4 stages of heart failure, and in stage A, patient at high risk for developing heart failure but with no structural disorder of the heart. In stage B, patient with structural disorder without symptoms. Stage C, patient with symptoms of heart failure associated with underlying structural heart disease. And in stage D, patient is with end-stage disease who requires specialized treatment strategy. So there is concordance with the two classification, and class 1 present stage A, class 2 stage B, class 3 stage C, and class 4 stage D. And even though this functional class, you can imagine from what treatment is need and indicated your patient with heart failure. What are the primary risk factors? Are the risk factors for coronary artery disease, especially hypertension, treatment of diabetes, tobacco use, obesity, high serum dyslipidemia, valvular heart disease, and hypervolemia, essential toxicosis, and different cardiomyopathy, different abnormal rhythm disorders, and heart valve disease. The symptoms and signs of heart failure, as taking history from the patient, is very important to take good history, because that making your diagnosis in more than 90% to what level in his life, in his ordinary activity, he received weakness, he received arrhythmia, have angina, and has changed something in his compliance, and has changed his therapy, or known previous disease. It's very, very important to ask full history of the patient, and that will help you about what kind of disease to think, and to what kind of diagnosis and therapy to treat your patient. So first of all is the history, is the physical exam. After that, ACG. No can examine patients in cardiology without ACG. It can give you the information about the rhythm, about the arrhythmia, about the risk for ventricular tachycardia, for hypertrophy, for previous myocardial infarction, and that's why ACG is more important non-invasive test for every patient who come to you for consultation. The next step may be X-ray, giving the size of the cardiac shadow, cardiomegaly, pulmonary congestion, or typical picture of pulmonary edema. Echocardiography is the golden standard for diagnose structural changes in the heart, according which can see is it systolic dysfunction, is it diastolic dysfunction, valvular disease, hypokinesia or akinesia of the wall motion of the left ventricle, indirectly pressure in the right ventricle, as measure and indirectly imagine the pulmonary hypertension. So heart failure is a clinical diagnosis, and in nowadays, without laboratory test control of creatinine, because as increase the creatinine level, you must stop therapy with potassium sparing diuretics. From other side, all diuretics give risk for hypokalemia, for hyponatremia, and that is risk hypokalemia, risk for sudden death, for arrhythmia. So the control of the levels of the electrolytes is very important. From other side, as you giving amiodarone in the treatment of atrial fibrillation, can the patient receive hypothyroidism or hyperthyroidism, and must control and thyroid hormones. So must looking very carefully for these parameters. Every anemia, every information also can increase the symptoms and worsen the heart failure. And diagnostic approach is medical history, including pre-existing condition, history of alcohol and tobacco, and also drug abuse, cocaine in the young people. And initial evaluation begin with routine laboratory test, especially test for BNP level and ACG and chest X-ray. Other procedures as stress test to objectivize the angina and the ischemia, and to see also and the functional class of the patient, can see the rhythm disturbances during physical activity. Also can making stress echocardiography in nowadays, using and 3D echocardiography, also and performing and strain echocardiography, and giving the segmental function of the left ventricle. So you can imagine Here on the X-ray, a big cardiac shadow. Here is the congestion in which uses also, and here on the echocardiography, the sizes of the left ventricle, which is right ventricle, it is right-sided, it is this is left atrium, this is right atrium, and during you can see with color Doppler, even imagine the mitral regurgitation if he coming to the end of the left apex and can see here the aortic regurgitation. Here you can see the also the aorta, the left ventricle. Here is the mitral valve. So different information. The thickness of the septum can see also as measured with Doppler. The gradient between right ventricle and right atrium can receive indirectly data for the pressure in the right ventricle, and as giving 10 millimeter as is the distance, can receive information about the pulmonary hypertension. Of course, in nowadays, a big information giving magnetic resonance for the structural changes. Here talk about in myocarditis, in other diseases which can be a reason for cardiomyopathy, but the cardiac catheterization giving the most information important about hemodynamic in the heart, to see what degree is the mitral regurgitation, what degree is the is the to receive pressure in the left ventricle, in the right ventricle, pulmonary hypertension, and to see is the patient, and of course coronarography, is to see is the patient will be have a need for operation, plastic of mitral valve for in severe mitral regurgitation. And other investigations have talked about blood tests as liver biochemistry, creatinine, cardiac enzymes, different nuclear cardiography nowadays. PET scan will be can also with stress and giving the information is there a vital myocardial, is the patient will receive receive benefit of recanalization of one full occlusive of old stenosis and to perform that intervention. Computer tomography also can demonstrate myocardial ischemia and dysfunction of myocardium, especially correct diagnosis of the chambers dilatation and also the structural changes. So first of all, ACG is recommended to see especially the QRS morphology, also because we have talked that resynchronization therapy improve the synchron of the contraction of the left ventricle and can improve even if the patient is responder to resynchronization therapy. We'll talk tomorrow about the treatment with these devices, but the QRS complex must be white as the form of flat bundle or orange bundle or inter but to be more than 12, and as more is dilatated, more good chance to respond to resynchronization therapy. Other side must looking for different arrhythmia and all tests can giving us a big information to diagnose the heart failure and to begin the correct treatment. Other diagnostic test, as you see, is glucose, glycated hemoglobin. Glycated hemoglobin give us information about around 2 to 3 months period before the test, and say us is that patient is compensated diabetes all the time, or because the diagnosis of diabetes in nowadays is putting only according glycated hemoglobin, and if it's more than 64 can discuss nuanced diabetes. From other side, if the patient is with glycated hemoglobin 9, even 11, this patient is with control of his glycemic status and must optimize that treatment. Of course, in the patient coronary artery disease is very important to treat dyslipidemia. If the patient have anemia, to investigate it, ferritin, and of course natriuretic peptides. Here are the good points for heart failure diagnosis. Imagine have patient with dyspnea in emergency department, and it's difficult to say is that dyspnea is from his pulmonary disease and is due to heart failure, and if in different ages different good points, but if anti-pro-BNP or BNP is under 40 heart failure, under 300 heart failure is unlikely, and his dyspnea may be due to pulmonary disease, other reason. But if you have anti-pro-BNP more than devastating, 900 picograms of milliliter, or as you see, the heart failure is possible, but maybe this patient is need for echocardiography to see is there other reason. It is also and in renal insufficiency inappropriately, but when anti-pro-BNP is more than 180, it's very typical. And now we have a patient in clinic with more than 20,000 anti-pro-BNP, other patient with myocarditis that is even not so big symptoms, have 4,000 picograms of milliliters. So it's important in these cases, but if have typical symptoms and structural changes, but if you compensate it with the drugs patient, and the patient again receive worsening of the symptoms, you can investigate anti-pro-BNP and see that he have peak of his anti-pro-BNP according his previous visit, and so have worsening of his heart failure, and see the reason for that worsening. In special cases, as is also patient indicated for cardiac biopsy, especially in cardiomyopathy, in transplanted patient, ACG 24-hour monitoring, and have talked about cardiac catheterization and right heart catheterization with pulmonary arterial catheter is recommended for all patients, first of all, candidated for heart transplantation or mechanical circulatory support, also to patients who remain severe symptomatic, although have optimal therapy and their hemodynamic status is unclear, in which discuss endomyocardial biopsy, thoracic ultrasound in nowadays, and especially in now pandemic period to look for congestion as it's very easy method in patients, especially with acute heart failure and maybe as measured inferior vena cava where have congestion, right heart failure, and maybe assessment volumic status. So it's very important to look for factors aggravated heart failure. Myocardial ischemia or infarct, very often the reason. Dietary sodium excess is very important because the sodium, as in now summer, in all salads, in all in all foods, we must think about excess with intake. But these patients are not to stop their intake. They need from food intake to test this water medication non-compliance. Very often the patient compensated in the clinic, we discharge them and they stop their therapy, and after 2 to 3 days begin again their compliance, their edema. They don't like diuretic therapy, excessive furosemide therapy, because must stay at home. And from other side, some patients giving increase of uric acid. That's why I must think about that, not to stop the therapy, to give them adenuric or neuric drugs who decrease the level of the uric acid, and also some infection condition associated with increased metabolic damage as pregnancy, thyrotoxicosis, excessive physical activity, and so every time patients with heart failure discuss have they take a lot of non-steroid drugs who ameliorate creatinine and giving increase of levels of creatinine, also with irritation, retention, and they taking about their gonarthrosis, gel pain, and must say them not to use them not more than once daily, not more than 2 to 3 days. Corticosteroids also can ameliorate and hypertension and renal function, and alcohol abuse also. So, in the patient with suspected heart failure, must think first of all for clinical history, from the physical examination for rails, for bilateral ankle edema, for heart murmur, for jugular venous distension, neck, and ACG abnormalities. After that, if perform echocardiography, ACG, and natriuretic peptides, and must think about other diagnosis or accept the patient in cardiology clinic to diagnose and compensate it. For tomorrow, we'll continue. Any question?